So just to somehow simply define the shockwave therapy or shockwaves in general, one needs to know what is a shockwave, why are we talking about the shockwaves, and what are they actually. So by the definition, they are pressure waves that have a very fast and high rise of positive pressure followed by a longer period of decreasing pressure. This is like a written definition, but to put it into the more easy words, more simple explanation, if you look at this graph in here, you might see that the shockwave is basically a pressure wave. If you imagine any wave in the natural world, waves in the sea, they are also sort of pressure waves, but the shock waves are somehow specific. What is specific for the shock waves is that they have they are very strong, which means that they have a high pressure, and they are also very fast. At this graph, this is basically what you can see anywhere on the internet and even on the ISMST, by the ISMST definitions. You can see that the rise in the pressure is extremely steep, which means that the wave is increasing its intensity very fast. We are talking about terms in nanoseconds, basically. So during the therapy, you will feel a very strong feeling, but it will be also very, very fast, basically. And then once it reaches the peak, the maximum positive pressure, that wave is again decreasing to its, let's say, original pressure. So this fast rise, it's followed by this smaller, let's say, slower decrease of the pressure, and goes even to a negative pressure. Basically, what is used? This is used in the medicine to carry this high energy into the patient's body. Since the very beginning, this was the whole idea, to get this energy inside of the patient's body to let's say have different effects inside of the human body. So it all started in 1980s. The whole shockwave therapy story started with something that it's called lithotripsy. These devices were they are still used in the hospitals, and these devices are much bigger than the one that you can see here. This is basically an office device for orthopedics and rehabilitation, but these devices were used, these lithotripsies were used for the urology to treat the kidney stones problems. As you can see on this picture, back in the days, the patients were submerged into, let's say, a bathtub, and the shock waves were passed through this water inside of the patient's body without any surgery, without any intervention, and without any damage of the patient's skin. So it was basically a non-invasive, and it still is a non-invasive procedure. The newer device, still the lithotripsy, now it's not necessary to put the patient into the bathtub, but it's possible to use these applicators and use ultrasound gel instead. So in these original devices, it was possible by this high energy to target the kidney stones inside of the kidneys, let's say, and destroy them. Literally, these waves were much stronger than the one that we are using in the orthopedics, and they were much stronger, and they were able to destroy, literally disintegrate the stones inside of the kidney. So the stone would basically fall apart, and then by the urinary tract, the patient would be able to eliminate it, to get rid of it. And in this very interesting procedure, the doctors, of course, they wanted to know what is happening to the skin and to the other areas that this shockwave is affecting. Is it somehow damaging the patient, or is it completely safe? And what they find out, they actually realized that on the X-rays, part of these waves were also going through or passing the bones. In this case, it was a pelvic area, and they found out that the area that was affected, the bone area, the pelvic bones affected by the shock waves, were after some time were actually more dense. So they found out that there is some other effects that the shockwave is doing, something else than only destroying this these kidney stones. And after this, they even still in 1980s, later 1990s, they were trying to find out how could this be used for patients' benefit. So the first, what happens after the lithotripsy, they started to use it for healing the bones, especially when it comes to the non-union bones, which means pseudoarthrosis and basically bones that are not healing after fracture correctly. So, and basically what they found out was that if you apply the shockwaves to the bone that it's damaged, you are able to stimulate these cells to grow or to formate a new bone structure. So there was something new to use the shockwave for. And then it was only a little step to try to find out what else can be repaired, not destroyed like kidney stones, but repaired by the shockwaves. And it was examined, for example, for the wound healing, especially with the diabetic patients with diabetic ulcers, and the shockwaves with much lower intensities than for the destruction of the kidney stones were used to treat the open wounds, and with a great success, actually. Then again, it was starting to be used in different areas to treat the tendinopathies. Especially it was used for the chronic tendinopathies and the damaged tendons. And nowadays, what we think in 2020 is that the shockwaves are basically able to stimulate variety of different cells in the different tissues, and to help these cells to repair these tissues. So this is how it was from the beginning. How it was from the beginning, and how it changed during the time, and how the path for the rehabilitation and orthopedic for the focus shockwave was found. So nowadays, most of these smaller devices, the office devices that are basically portable, they are used to treat the chronic disorders most of the time, and somehow to provoke reparation processes, which means to stimulate the cells in the way that they would start to do what they should normally do to repair the injuries or to repair the damaged areas, and to enhance this process and make it faster. Basically, we will see some studies at the end of this webinar where it's compared basically the healing process with and without the shock waves, and we will see how is it possible to improve the healing process. So the most common applications that are used now in the rehabilitation clinics are chronic tendinopathies such as tennis elbows, plantar fasciitis. These are very common. Then calcifications, most of the time, or very, very common thing is to treat the calcifications in the shoulder area, in the supraspinatus muscle, in the tendons of the supraspinatus muscle. And bone non-unions, whether it's long bone non-unions such as femur or tibia, or if it's smaller bones, even let's say metacarpal and carpal bones in the hand. And in general, it's used for the chronic pain, which means chronic pain caused by the tendinopathies, caused by some muscle disorders, in general musculoskeletal apparatus. This is a very important slide of the presentation where I'll try to explain what are the differences between different technologies and how are we standing in this portfolio, which is currently available on the market. So basically, there are two main technologies when it comes to the shockwave. The first one is the radial shockwave, which is most devices are run on the pneumatic principle, which I will explain a little roughly on the next slide. The biggest difference is that these are called radial and not focused because the wave that they are producing is basically it's spreading divergently. As you can see on this graph, it's spreading divergently, and it's getting wider with the distance. When it comes to the focus shockwave, it's exactly opposite. These waves of the focus shockwave are starting, let's say, in the wider area, and they are with the distance. They are getting smaller, but they are also increasing intensity. So at the tip of these pictures, as you can see, the intensity would be highest. When it comes to the focus shockwave, in general, there are more technologies, more, let's say, availability of the technology on the market than when it comes to the radial shockwave. And let's talk a little bit about each of them, and somehow let's talk about the advantages, disadvantages, and also the how they were made. So the first focused shockwave devices that were developed in, as I said, 1980s were the so-called electrohydraulic devices. These are, let's say, the oldest devices on the market. They are very powerful. They have a very strong, they produce very strong shockwave, which means a shockwave with very high pressure. But they have one big disadvantage, and that's that the electrode which is producing the focused shockwave has a very limited lifespan, which means that after a couple thousand shocks, it needs to be replaced. So basically, this one is clinically, it's a very good device, but it has a disadvantage of that on one hand, it requires lots of maintenance, and it is also, in many cases, it's very expensive and time consuming to change the electrode in this device. The second type of the focused shockwaves is something called piezoelectric, and that's, let's say, a very opposite of the electrohydraulic machines, because the focus or the shockwaves produced by these devices, they are much weaker, and they are much weaker, and they also are, let's say, more narrow. So they would only affect a very small area at the end in the concentration point, which is called a focus point. Basically, I will get to this topic a little later. These piezoelectric devices are formed basically by many, let's say, hundreds of piezoelectric crystals that are mounted on the applicator. And each of these crystals is possible to, under high voltage, they are deformed. And once they deformed, they are producing these low energy shockwaves. But since you have hundreds of them on these devices, they are producing, each of them is producing a small shockwave. And like by concentrating of these shockwaves, they are creating a much stronger wave. Why I said that it's very opposite from the electrohydraulic, the thing is that with piezoelectric devices, the lifespan of these applicators are much higher. We are talking about few million shocks that are possibly to be applied before a necessity of the servicing or necessity of any maintenance or changing the applicator. So there will be a second type, and the third type that was current until these days on the market. It's electromagnetic device. Some of you might know the company Storz, which is probably the biggest company that has this type of technology. And clinically, it's a very good device. I have to say that these devices they have a very good clinical results. They are sort of, let's say, golden standard in the clinics. They are very, very powerful, and they also have the size of that accumulation point. It's quite large, so it's easy to target the areas. They are somewhere in between the two previous devices. They do have a limited lifespan, currently about 1 million shocks. So a rather limited lifespan of these devices. But as I said, clinically, when it comes to the power, it's a very good device. So clinical results with these devices are well. And then the only technology that we are left with is the electroacoustic device. This is patented technology by the BTL. At this time, it's the only, basically, we do have the only device with this technology because we developed it our own, and you cannot find it elsewhere on the market. From the beginning, what we wanted to do was to see the market and to see the other devices and take the advantages and put them together. So there are basically these two types, lifespan, and then the clinical results, or let's say the power. If I say power, means high pressure of these devices, and put them together. So this was the whole idea, what we wanted to do in this in our device. And basically we managed. We wanted to have comparable parameters, clinical parameters, as with the electromagnetic or electrohydraulic devices, but we wanted to have a very high lifespan such as piezoelectric devices. We achieved this by basically putting together a bunch of things, and we got inspired by all the previous technology. So currently we are using this electroacoustic lens system, which is the brighter blue part of this picture, and underneath we have basically one single piezoelectric crystal. Sounds similar like piezoelectric technology. The biggest difference is that the piezoelectric technology is using hundreds of these small crystals, whereas we are only using one, which is much stronger, much larger, and it's able to produce much higher intensities. So these are the 4 technologies that are currently on the market, and basically this is the idea how we wanted to position our technology basically next to them. If we put these 2 technologies next to each other and look at the pressure that it's created, or the wave, the shock wave that is created in them, the biggest difference is that with the radial shock waves, in general, they are able to treat more superficial areas because they do not possess the ability to focus their strength, their pressure. So it is possible to only to affect the superficial areas. Depends also on the patient's body, how deep is the injury, or how deep is, let's say, a tendon that I want to treat. But in general, the radial shock waves are more superficial, whereas with the focus shock wave, it is possible to adjust the area that I want to treat. It is possible to adjust on the applicator and get inside of the patient's body, or even on the superficial area. But the biggest difference is that with the focus shockwave, you can choose which areas inside of the body you want to treat. With the radial shockwave, it will be a little limited because you don't have the ability to change this. Now, before we get to the clinical effects, like a little bit more deeply, I would just like to mention that in general now the devices, both focus shockwave and radial shockwaves, are used for these most common to provide these most common therapeutic effects. Basically, it's muscle relaxations, elimination of the calcifications, as I mentioned, especially shoulders or plantar fasciitis when you have a calcifications build up. In general, for the pain relief, especially for the chronic injuries, and in general for the tissue regeneration, which I will explain in this next chapter. So to understand the effect that it's provided by these devices, just to very simplify it, to have a very let's say to have a like the idea of the basic idea how the shockwave works. The first thing that is need to be done is to somehow get this shockwave inside of the patient's body. So it depends on how it spreads, because the shockwave spreads through the different tissues differently. If you have a high amount of water, the shockwave would spread better than if you have some other material. Let's say through the air, the shockwaves will not spread at all. They will be reflected. So it's based on the amount of water inside of the tissue, and also based on the density of the tissue. So the human body is ideal for this, as the environment is mostly, or the tissue is mostly made out of water. But you have to keep this in mind for the treatment, because, for example, through muscles, it will spread better than through the bones. Through the bones, it would get reflected, and some of the energy will be absorbed. So the first thing is to get it to the patient's body. Then once the shockwave area is reaching once the shockwaves are reaching the area that you want to treat, they are causing cell stimulations. The cell stimulation is basically done by this pressure or this energy, and upon this stimulation, the cells are able to produce growth factors, which are basically proteins that are basically proteins that are produced by the different types of cells. And upon this stimulation, the cells are also able to proliferate and differentiate, which means to grow in number and also to grow into more sophisticated stages of their lifetime. And this all results in the tissue regeneration. To summarize it very simply, by the shock waves, it is possible to stimulate the cells, and these cells, upon the stimulation, are increasing the effectivity or efficiency of they are normally supposed to do. So they are faster, providing the body the faster results that they would normally do without the use of the shockwave. We have a question now in the chat. How is the cell stimulation produced? Through heat or vibration? Not through the heat. The heat is basically not present in the focused shockwave that much. We are not talking too much about the heating effect, but the vibration would be the closest. And it's something called mechanotransductions, which basically means that the cells in general are able to respond to a different stimulus. And when it comes to the mechanical stimulation, they're responding by these production of the growth factors, to releasing of these proteins. It's a very common question if there is any like heat feeling during the therapy. Not really during the therapy. Basically, you would not feel the heating of the tissue. You would only feel, I would compare it with probably the pressure is the best thing to say, but it's compared with the focused shockwave, something like a little bit of the piercing needle kind of sensation. During the vasodilatation, yes, it is proved that vasodilatation it's done by this mechanical stimulations, especially when it comes to the radial shockwaves, because they are basically able to stimulate the blood flow. You can see it after the use of the shockwave on the muscle areas that you will have this redness, which means basically that the more blood flow is provided to the area that is treated. So another thing which is very common is that users are asking if it's normal that you can see the redness after the therapy. Very common use, more with the radial shockwave than with the focused shockwave. Okay. Through which growth factors focused shockwave or extracorporeal shockwave therapy promotes tissue regeneration? This is very different. Basically, depends on the cells that are being stimulated. There are factors for, like, the most common thing is basically the neovascularization, which I will talk a little bit later. And these are factors, VEGF factors, that are very common for the neovascularizations and providing basically a new growth of the blood vessels. So the vessel endothelial growth factor is probably the most common. And also when it comes to the studies, it's the most well-known, understood factor. Other factors could be, let's say, transforming growth factor, beta-1, and insulin-like growth factor. Such factors in the tendons, especially, very common and very well described in the studies. I see in the chat, Anand, you already answered the angiogenesis. Yes, it's the endothelial growth factor is the main factor that is doing that is providing the angiogenesis, basically a neovascularization, the growth of the new cell. I will skip to the next slide, which is about this topic. So as I see already mentioned in the chat, you can see that if you stimulate the areas which are not well provided with the blood flow, you are also influencing the vessels. And upon this providing energy to these vessels, you are able to produce these growth factors, or the cells are able to produce these growth factors, and that is how the neovascularization is achieved. This was another interesting topic, which is very common to discuss when it comes to the shock waves, because the neovascularization is important for the healing of variety of injuries, such as chronic tendinopathies, or even the bone healing, but also the focused shockwaves are used in the urology, and they are used for the treatment of the erectile dysfunctions. And this is the key. This is the key thing to influence the blood flow during the erectile dysfunction, to provide better blood flow through angiogenesis or neovascularization. In simple words, growing a new structure of the cells, providing new blood supply. So yes, so this is basically the neovascularizations, which is used. This is probably the most common effect that we are achieving in various diseases, means tendinopathies, urology, bone healing. This is an effect that we are providing in most of the cases. Another effect when it comes to the tissue regeneration is also the stimulation of the cells that are found in tendons by stimulation of the fibroblasts. And again, we are producing the growth factors and be able to basically heal the tendons through production of growth factors, and able to stimulate these cells to produce more collagen and to repair the injured tissues. At the end of this presentation, I will provide you some of the studies that I'm mentioning here, and we will look at some graphs that are proving, let's say, the amount of collagen that is being produced after the shockwaves and without the shockwaves. Okay. Another effect that I want to mention is a fracture healing. This is specific to the focused shockwave devices, and it's not possible to use this is not possible to use for the radial shockwaves. Basically, this is one of the few indications that you are not be able to even try with the radial shockwave to heal the broken bones, to heal the fractured bones. This is actually an X-ray that was already done with our device. One of the first patients that was treated with the focused shockwave with the indication of the non-union. I believe this was done in Latin America. And this was a very interesting case. This was a patient who had the fracture. And as you can see on the first X-ray, you can see that the bone was already operated. The surgery was done. The consolidation of the bone was done already. But this picture was taken 5 months after the surgery, after these implants were done into the patient's body. So as you can see, even after 5 months, there is literally no signs of the bone formation. You can see that the fracture is still very much visible, and after 5 months, it's something that is definitely going to be classified as a pseudoarthrosis or non-union after this long time. Then this is the second picture, which was taken 3 months after 3 applications of focused shockwave treatment. This was already done with our device, as I mentioned, and this is after 3 therapies and after 3 months follow-up. And you can see that the bone is finally starting to form in the area that it was fractured. We have another question. For superficial tendinopathies or superficial calcification larger than 6 centimeters, which one is better, focused or radial? When it comes to the superficial tendinopathies without calcifications, I think it's clear that you can easily use the radial shockwave. But when it comes to the calcifications and superficial calcification or calcified tendinopathies, it is better to use the focused shockwave for one reason. If you want to treat the calcification, which is, let's talk about the calcifications in the supraspinatus muscle, and the focused shockwave devices has 2 benefits over the radial shockwave when it comes to treatment of the calcification. The first one is that the energy provided is much stronger. Whether you choose superficial or deep tendinopathies, it doesn't matter. The focused shockwave in general has much stronger or much higher pressure. So the results are usually seen much sooner, and we are using also less amount of shocks when it comes to the focused shockwave. So in my experience, definitely focused shockwave is better for the calcification. The second benefit is that it's much easier to target with, because you know that you have this focal point, which is the accumulation of the maximum energy. Whereas with the radial shockwave, the wave is like it's getting divergent, it's getting wider, so it's much easier to target these the calcification with the focused shockwave. I will demonstrate I will try to show you how to change the depth of the penetration with the focused shockwave, which is something that on the radial shockwave it's not possible. Why is not possible? Another question: why is it not possible with radial for bone healing stimulation? There are two reasons why. Again, two reasons why is it not possible. The first one is, if you ever tried to apply the radial shockwave on the bone, it's extremely painful. With the focused shockwave, the painful is also presented, but it's a different kind of pain, because as you with the focused shockwave, you do not have the metal transmitters that would be hitting your skin, and of course, if the bone is superficial, like tibia, for example, it wouldn't be hitting metal on the bone. That's one thing. And the second thing, which is probably even more important, is that you are not trying, if you take a look at the picture, you are not trying to affect this whole area. What you are trying to do is to affect the area that is not, that is basically where the bone is not formatted. So the area where the cells are basically doing something to repair the bone. So with the focused shockwave, you are able to target much more precisely than with the radial shockwave, the small areas that are fractures. Another thing, when it comes to the radial shockwave, it hasn't been studied well enough to have like strong clinical backup information to prove the effectivity of the radial shockwave. The reason most likely is that these devices are simply not as strong, and it's harder to use them for the bone indications such as pseudoarthrosis. Okay, let's say there are more and more questions. I will try to answer at least some of them. Those that will not be answered, you will hopefully get to them later. We will contact you through email. Let's do one more question before we move on the other topic. Can you apply focus or extracorporeal shockwave therapy on any osteosynthesis material? No, basically no. This is a very good question, because as you can see on this area, you already have, let's say, screws, wires, whatever material would be inside of the fractured area, or the area that was performed the surgery upon. Generally, you try to avoid them. In this case, it is possible, if you take a look at this X-ray, it was possible to avoid even this area and only affect the insides. Basically, you have to choose. You have to have an X-ray in the first place, and you have to know which way you are aiming with the focus shockwave. Since the focus shockwave are very precise, it is possible to avoid these areas, but it takes a very experienced user, because otherwise what would happen, we will talk about the contraindication later in this presentation, but what would happen, it would cause a lot of pain, and possibly it might cause a disruption at some point of the material, especially at the attached place. I will explain this when we get to the chapter of the contraindications. So with the focus shockwave, you are able to target this area, whereas with the radial shockwave, for example, as was the previous question, you would not be able to avoid these osteosynthesis materials. That is why the radial shockwave is also not recommended for the use on the pseudoarthrosis. Okay. So let's finish this chapter, and I will get to the question. I'll get to the other questions. I'm sure that you will have more questions after finishing all of this of this chapter. So I'll try to answer them as well. Another clinical effect that is possible to achieve, it's we already started this topic a little bit, the calcifications. Basically, with the focus shockwave, again, it's much easier to target the calcifications. The deeper they are, the harder it is to achieve them with the radial shockwave. So that is where the focus shockwave is getting superior, and it's possible to target the small calcifications that are hidden underneath muscular areas or tendons. In this case, for example, again, this is one of the clinical cases that we already had and it was done with our device, and it was a patient with a subscapularis calcification in the subscapularis muscle. And as you can see, the follow-up was again done in a 3 months period after three treatments of the focus shockwave, 3 sessions. As you can see on the picture after, or the follow-up picture, you can see that the calcification is no longer visible. And very common question in this case is, why is it not there? What happened to it? Was it destroyed? Was it how did we get rid of it with the shockwave? The answer for if it was destroyed, no, because the calcification in most of the stages that at least from my experience, they are not ossifications. It is not a stone type of material. The calcifications are, if you would perform surgery on it, it would be more of a, let's say, a paste, like a toothpaste material. It's a soft tissue, so you cannot technically break it apart as it was done in the lithotripsy with the urology stones. But in these cases, the most common theory of how is it, let's say, eliminated, not destroyed, but eliminated, this calcification, is by stimulation of the lymphatic vessels. And again, providing the lymphatic system some impulse to reabsorb this material. This is probably the most common theory of how the calcifications are removed. So in these cases, I would get back to it immediately. Very common thing is the plantar fasciitis and heel spur, whether or not I can destroy heel spurs with the focus shockwave or radial shockwaves. Not destroy, I cannot destroy the ossification on the heel spur or the heel spur itself, but it's not most of the time what I'm trying to achieve. As you might know, the heel spurs are basically ossificated areas that if we would destroy them, there would be some bony areas flowing around inside of our body. That is why the surgery, during the surgery on the heel spur, it is basically shaved off and taken out. The material is taken out from the patient's body. But when it comes to the focus shockwave, you are not disturbing the tissue. You are not disturbing the skin. So the material or the heel spurs are most of the time, they are, let's say, it's not possible to destroy them with the focus shockwave devices, but what they are causing, which is most of the time inflammation, chronic pain, this is what you can treat with the focus shockwave. So you can treat the symptoms that are causing the pain, but you are not destroying any areas, because that would technically mean that you could be able to destroy bones, which it's not possible with the focus shockwave. You are not destroying any bones. The energy is simply not set as high that it will be possible to destroy bones. So this is let's say a little summary of what we are discussing. Let's go quickly through this slide just to summarize it, to have a basic idea especially for the people who are new to the shockwave, what is possible to achieve with the shockwave therapy. So in general, the most important word would be the cell stimulation. And then let's take a look of what we can stimulate. We can stimulate the lymphatic vessels to promote the growth factors and cause the elimination of the calcification by basically reducing the amount of material by reabsorbing it again through the lymphatic system. Another cell stimulation is used for the bone growth factors and to cause bone repair, as with the non-healing bone fractures, pseudoarthrosis. Another effect is collagen synthesis when it comes to the disrupted tendons, and we are able to increase the production of the collagen and cause the tendon repair. And last but definitely not the least, neovascularization process, which is again done by the cell stimulation, producing of the growth factors. And upon this improved blood supply, we are also helping tendons to repair when it comes to the chronic tendinopathies, and also the bone repair when it comes to the pseudoarthrosis or bone non-unions. Okay, so let's also talk about another topic, which is the effects that are immediate, because all these effects that are done by the focus shockwave are they take some time. The bone repair, of course, it takes some time for the body to repair. The tendon repair, the same. It takes some time for the elimination of calcification. It will take a couple of weeks before you can see some results. But from the experience that I have, and also from the experience of the colleague or the people that I had the chance to talk to, there are also some immediate results that you can see after the therapy. This is basically a typical scenario is that the patient will come with the plantar fasciitis, and basically they say that they have it for 1 year and nothing's helping. They lay down on the bed, you perform the therapy, and right after, when you finish the therapy, they say that it's immediately better. This pain relief usually lasts for a couple of days, couple of weeks. Sometimes it gets worse. Sometimes it gets to the same stage that it was before. But in the general, to treat the not only the symptoms but the cause, it takes some time. But why do we have these results like immediately after the therapy? It is explained by the gate control theory or gate control mechanism, which is a theory of the pain, which is one of the most common pain theories, and it's based on the fact that we have a nerve, basically the nerve paths that are different. We have some path that is leading the pain. Those are done by the nociceptors, and they are basically a different nerve fibers than the one that are leading information about the mechanical stimulation. So if we would only feel the pain, as you can see on this the red part with the nerve, that's basically a nerve leading to our brain, that you can feel the pain through these nerve fibers. But at the same time, if you put the sensation of the mechanical stimulation, you are activating an interneuron which has the ability to inhibit the lead of the pain or the path of the pain leading to the brain. So the classic example of this theory is when you wake up in the morning, and when waking up, you stub your thumb on the side of the bed and you start jumping around, you start rubbing the area just to have some more stimulus for the brain or for the body to forget about the pain. So this is one theory, how does it explain the immediate results. Another, let's say more biological theory is that the regulation of the substance P. The substance P is a mediator or a neurotransmitter that is responsible for leading the information about the pain. There are some interesting studies that basically were measuring the amount of substance P after the use of the shockwave immediately and in the long-term period. Immediately after shockwave, you have increase, or the patients that the shockwave is applied on, they have immediate increase of the substance P, which is also explained by sometimes the pain during the therapy, and slightly after the therapy, you can feel some pain. This is explained by the increase of the substance P. But in the long-term period, talking, let's say, a few days and then lasting for few weeks, the level of this substance P is decreased. So in general, you are doing this, let's say, opioid kind of therapy, but without the drugs. And then the last effect, which is especially for the radial shockwave, not so much for the focus shockwave, is that immediately after the therapy, how does it affect the muscles? You are able immediately after therapies, when it comes to the trigger points, for example, you are immediately able to disrupt the trigger points and to relax the muscles. This is explained also by something called muscle stiffness-pain cycle, also called a vicious cycle, where if you have a muscle which is painful, it gets stiff, and when it gets stiff, it blocks the way, or it blocks the supply of the blood that is bringing oxygen to the muscle. And when is this blocked, the muscle gets stiffed even more, which is even more painful. So it's a cycle which you can disrupt by the relaxing these muscles by the mechanical vibration of shockwave. Let's take a look on a few other questions now. Can I use shockwave to a case with a muscle spasm to medium trapezius and supraspinatus muscle next to the spine if the person has also cervical-brachial syndrome to C4, C5, C5, 6, and C7? Thank you. In general, it is possible to relax the trapezius muscle with the focused shockwave, but you have to be very careful not to get close to the spinal cord and basically to the spine, because if you would be close to the bones, and doesn't matter if it's a shockwave focal or shockwave radial, it will be very painful. Also, what we want to try to avoid, if necessary, we are trying to avoid the application on the nerves. Until, of course, there are some experimental studies that are where the shockwave is used for the nerve reparation. But again, these are mostly experimental studies done on the animals, and it is not yet provided as a, let's say, as a thing to normally treat like nerve reparations. Okay, let's continue with the presentation. So just to summarize this, the other part, through the shockwave energy and mechanical stimulation, we can achieve the substance P regulation, which is responsible for long-lasting pain relief, gate control mechanism, which is responsible for immediate pain relief right after the therapy, and of course, improved blood supply through the muscle relaxations. Let's take a look on the therapy guide. Very briefly, let's talk about the parameters that are concerned when it comes to the shockwave therapies in general. What are the differences and between two technologies? So the first parameter is the intensity. As I mentioned, some of the devices are stronger than others. When we compare focused shockwave and radial shockwave, when we compare these two devices, one is using the radial shockwave is using bars as a unit because, as I mentioned, is the pressurized air is inside of the device. That's why we are counting bars. It's inside of the device, and we are measuring how the air inside of the device is pressurized, how much. Where it comes to the focused shockwave, we are talking about energy flux density, which is specified by millijoules per millimeter square. We are not talking about the inner aspects of the device, but we are talking about the energy of the shockwave outside. This is usually measured by the optical hydrophones. And just for this basic seminar, it's important just to know that there are differences between two technologies. And for example, it is not possible to compare bars to EFD, to this millijoules per millimeter square, because as I mentioned, the bars are inside of the radial shockwave device, whereas the EFD is outside with the focused shockwave device. In general, intensities, the recommendation is always based on the patient's feeling, how intense the therapy perception is. So we are always starting with a low intensity, and we are increasing it based on the patient's feedback. But in general, there are some recommendations that I can mention, that the lower intensities are usually used for the dermatology and subacute issues. Dermatology means mostly wound healing. Higher intensities are used for the chronic tendinopathies, muscle disorders. And even if we go even higher, it's chronic calcifications where we use higher intensities, and chronic bone issues, the highest intensities of all. That is also answer why we cannot use the radial shockwave so much, because it's simply not that strong. Another parameter is amount of shocks. In general, just to remember that focused shockwave, that in focused shockwave, we are using in general less maximum shocks. With the radial shockwave, you can go up to 4,000 to 6,000 shocks. The reason for this is that you can, when you are treating, for example, calcifications, you can also treat the rest of the arm, treat the trapezius muscle, or any part of the body. You can redistribute the amount of shocks like through the different areas. Whereas in shockwave focused, you are trying to affect the area which is mostly damaged or mostly injured. Another parameter is the frequency, which means basically how fast I am delivering the shocks, with what frequency, which is specified by Hertz, means how many shocks per second I am delivering. Again, we can recommend some frequencies that are mostly used for different types of effects. Let's say for the tissue regeneration, if you want to be very precise and want to just chronic tendinopathies, which has like micro tears in them, you are using lower frequencies because simply it is easier to target. You can increase the frequency a little bit for the calcifications and even higher for the muscle relaxations. In general, the highest frequencies are used for the common pain relief and causing this gate theory, gate pain theory, like the effect of this theory, basically. Because with higher stimulation, faster, the body is able to have more perceptions, and you are able to to achieve the stronger or the more efficient results. Another thing which is very specific and very different for respective devices, radial and the focus shockwave, it's penetration depth. So as I mentioned, you can with the radial shockwave, you are sort of limited with the pressure, with the penetration depth. But with the focus shockwave, you are able to adjust how deep you want to get, and how, let's say, how deep you want to get with the focus shockwave, and how deep you want to get with the maximum energy. Let's check some questions. Is this the same with electromagnetic focus shockwave? Principally, it is the same. Both devices are focused shockwaves. So let's say the type of the wave that is being distributed to the body is very similar. It's increasing its intensity with the distance, which I will have on this another picture. So here we have a radial shockwave, and as you can see, the pressure or the shockwave is spreading through the device divergently, which means that in here on the beginning, where you can see the dark blue color, it's much stronger also and much smaller. But with the distance, it's getting wider, but at the same time, it's losing intensity. Okay, so with the distance, if you would, that's a perfect example. If you have some calcification that is, let's say, deep inside of the patient's body, you are not able to affect it with enough strength, enough intensity, because the problem is that you will have to use the maximum intensity, and you will have this maximum intensity superficially. So you will be affecting the skin and the muscles with very strong perception, very strong shocks, but at the same time, you will not be affecting the calcification with enough intensity that you need. When it comes to the focus shockwave, it's exactly opposite. You are basically increasing the intensity with the distance, and you can adjust how deep you want to have the maximum intensity. So the difference is that in the focus shockwave, you have the ability to choose where exactly in the tissue you are and at which intensity you are using. Okay, so when it comes to these differences, with the radial shockwave, you are limited. With the focus shockwave, you have full availability of adjusting both penetration depth and also the power or the intensity of those waves. For to adjust basically these the penetration depth, you are using something that we call coupling pads. These are pads that you are able to put on the applicator, and you are basically changing the distance from the patient's body to the applicator. Okay, so the difference is that if you use these, I hope you can see it also on the camera, there are different types of coupling pads with different sizes. This one is the middle one, this one is the biggest one, and then once you mount it on the shockwave device with this lock ring, you are able to position the distance of how far is the tissue from the applicator. Okay, so with this one, we would treat very superficial tissue because the distance is quite far. As you can see on the presentation, we are able to use it with one transmitter. The penetration depth of this maximum intensity area would be from 0 to 35 millimeters. With the middle or M size pad, it's from 15 to 50 millimeters. With the smallest pad, you can go up to 30 to 65 millimeters of the maximum intensity. So even in these 6.5 centimeters, you would be not losing any intensity, and you can set it on the device however you want, and still you can achieve the same intensity deep inside of the tissue. And then another parameter which is specific for the focus shockwave is something that we call focus zone, and this is basically a fact that how large is the area inside of the tissue that has the highest intensity. So this is important because some devices has this, the focal zone or the focal point are very small, and it's hard to locate the, for example, tendon or calcification. So that is why when the devices are compared, basically the bigger focal zones are more user friendly because it's easier to affect or to target and affect the desired tissue. Another question: if you combine tiered therapy with focused, which is better to use as first choice and second choice in general? The tiered therapy, I assume that you mean the targeted radiofrequency therapy, the TRT therapy. The combinations of these devices, it is basically like both. It works both ways, depends on what you want to achieve. For example, I'm using TR therapy before for the patients to more relax and to get adjust for some further like let's say further therapies which are much stronger. With the focused shockwave, the procedure is much more stronger, the perception. So first I want to prepare my patient to relax. On the other hand, even the laser therapy and TRT therapies are also used for example, as with both with radial and focused shockwave, they are used to decrease the amount of pain, again to relax. So you prepare your patients for the therapy, which is maybe a little less comfort, and then at the end you want to stimulate even more the cells and, for example, provide more blood supply. So I would say that you can do both in general, because you are providing with the TRT therapy, for example, you're providing a very good immediate blood supply because of the heat therapy. So what are you doing? And this is lasting for a long time. In general, the focused shockwave, the whole therapy takes about 10-15 minutes. So if you do it before and after, doesn't really matter, because the effect will be there presented for a longer time, and you are able to combine it before and after, and you still have these effect put together at the same time. Okay. This is a very quick guide, very simple guide for the differences between two technologies, focused and radial. What would be the choice number one for focused shockwave? What would be the choice number two for focused shockwave, and so on? In general, superficial injuries or superficial problems such as trigger points and tendinopathies are treated well with a radial shockwave device, but at the same level you can treat it with the focused shockwave device, because you can also adjust it for the superficial treatment. The reason why this is the first choice is because the radial shockwave is simply more available, and it is not necessary in all cases to immediately go to the focused shockwave device. On the other hand, once we get deeper to deep trigger points, deep tendinopathies, and it is better to use focused shockwave device, because you cannot simply achieve it as well with the radial shockwave device. Tendinopathies at the bone tendon junction, absolutely focused shockwave device is more suitable, mainly because it's easier to target it and it's not so painful for the users that know how the radial shockwave is painful close to the bone areas. You know that this is let's say the patients can feel strong discomfort on the bone areas. So for this, focused shockwave is better. It's in general, it's less painful on these areas. For the calcifications, in general, focused shockwave device is superior over radial shockwave because of its ability to provide higher energies, and also the ability to aim. And for the bone unions, as I mentioned, it's the focused shockwave is the only one that is being used currently. Okay, these are some recommendations for the therapy. Generally, you want to adjust the intensity always based on the patient's feedback, because every patient has it different, and you want to start with the low intensity. Also take in consideration that on the bone, these therapies are not so pleasant, so it's necessary to avoid them. After the treatment, we recommend at least 48 hours of some rest of that area that has been treated. For example, if you have a tennis player with a tennis elbow, don't let them play tennis for the next 2 days. Recommendations. And again, some gentle rehabilitation such as stretching, it's possible. Interesting chapter, contraindications. Let's go quickly through the main ones and understand why we are not able to, or why we should avoid using focused shockwave for certain areas. After corticosteroid injections in the application area, we don't recommend it for at least 6 weeks because these especially tendons might get fragile and there is a possibility of the rupture. For the implants, as I mentioned, it is it's contraindication to apply it directly on the implants. If we are able to avoid these implants, it's possible, but it's definitely contraindication to like apply it right on the as you mentioned, prosthesis. For the growth plate areas in the children, in general, therapies like focused shock waves and others are not recommended because we don't want to affect the normal growth of the patients. Very maybe something that is new is that the focused shockwave is strictly prohibited on the areas with possible gas content, such as lungs or intestines, because we want to avoid them because the pressure or the shockwave would not pass through these areas, but it would get concentrated on the border of the air and the tissue, which gets, and there where it could get, let's say, reflected, the intensity would be too strong that if you have some, for example, someone with fragile or unhealthy lungs, it would be possible to cause some micro tears. Same for the heart area, especially when it's damaged, even though there are experimental studies with the focused shockwave to treat the heart because of the angiogenesis again. We are not applying focused shockwave for cancerous areas, for the patients with cancer in general, for the tumors, because simply you don't want to add extra energy to something that is growing like a tumor. Head and neck area, it's also prohibited simply for the high number of the nerves and brains. Spine area, again, we want to avoid it because of the pain. We have a question about if it's possible to apply it on the broken ribs. Technically, if you are able to palpate, good enough, and you will be sure that you are not affecting the lungs, you would be able to do it. If it comes to the pseudoarthrosis, if you have a patient with the pseudoarthrosis with the broken ribs, which is definitely one of the not so common cases, but it's possible, I would say that it's applicable if you know that you are able not to affect lungs. Simply put like that. If you are able to avoid them, yes. If you are not able to avoid lungs or possibility of treating the lungs, I would not recommend to use the focused shockwave. Another question about osteonecrosis of the knee. Yes, for the osteonecrosis, it is possible to apply the shockwaves. The reason is why it is applied quite widely and is used because of this ability of the neovascularizations again. So the new osteonecrosis is, let's say, a common thing to treat, although it's not as common as rehabilitation stuff because simply more patients suffers from these. Okay, this the preparation phase, basically I think I can skip it because I already showed how the pads are placed on the applicator. The only difference when it comes to the radial and focused shockwave is that you are applying 2 layers of the gel on the focused shockwave device. You have to apply the ultrasound gel also on this lens. So 1 layer of the ultrasound gel would come here. You would lock the applicator, and then you would apply ultrasound gel here or on the patient's tissue, basically. Whereas with the radial shockwave, you only apply 1 layer, and you are doing it exactly with the transmitters. Let's summarize the product features. As I mentioned on the beginning, why we build this device in the way we build it, and what are the features of this device. In general, as I mentioned, what we wanted to do, we want to put these 2 parameters together: highest lifespan and good therapeutic parameters, which means the performance of the device, the strength of the pressure wave or the focused shock wave, and the size of the focus zone. Another question, what will be the duration between 2 sittings in focused shockwave therapy? In general, it's the recommendation is 1 to 2 weeks based on how serious it is. Most cases is 1 week period would be recommended for the rehabilitation purposes. Some cases it's recommended 2 weeks. When it comes, for example, for the some of the non-unions, the recommendations might be 2 weeks, but 90% of the cases is 1 week approximately. So to summarize, basically, when it comes to the focused shockwave devices in general, they have a very high rate of treatment success, which I will show you also in the studies. It's a nice alternative to some surgeries, especially when it comes to non-unions, and it's non-invasive, so it doesn't have the risk of the problems, doesn't have the risk that are, let's say, related to the surgeries. And in these cases, as I mentioned, that most injuries we are causing the treatment of the not only symptoms but also for the cause of the problem. So we are with the focused shockwave, it's possible to do the permanent pain relief, especially with these chronic areas. When it comes to the side effect, for the past 2 years that I have been using the device, the only side effects that I have, and it's basically the one that are in the literature stated, is the let's say the pain after the therapy, which is then usually in less than 8 hours it's relieved. Another question with the treating of Osgood-Schlatter, usually I didn't have any experience with the treatment of the focused shockwave of these indications. Based on the experience that I know from the doctors that I mentioned, it's possible to treat it. Although when it comes to the younger patients, these more painful therapies such as focused shockwave devices are sometimes avoided or not put in the first priority. So I cannot unfortunately speak from my experience on this indication. Common side effects. In my practice, basically only the one is that the pain might increase for sometimes after a couple hours. Most very common case is I'm not sure if I can say that it's a side effect. It's more of a natural process of healing. Whereas some of the chronic pains, and if they are very strong, especially, the patient will say that after the therapy, after a couple of hours, they cannot even stand on that area that was treated, plantar fasciitis, for example. But next day, after they slept, it's much better than before. This is basically very common in both radial and focused shockwave therapy, that first you are increasing because you are restarting this healing process. So you know that the body is responding in some way, and usually it's not a bad sign. Question about the tendon ruptures. Very, very good topic. I had some patients who had a tendon rupture, but in these cases, it's recommended to do it when it's a tendon rupture, which is a chronic disease, which means that it's partially at least growing back and it's still problematic. And what you want to use definitely is to choose a low intensities. As I mentioned, for the tissue regeneration and for these subacute injuries, which definitely a rupture can be, you would start with very low intensities, which the patient will be definitely able to withstand without any discomfort. Usually these are intensities coming from 0 to 1 to 0 to 1.5 millijoules per millimeter square. So yes, it is possible to use it. I would not use it definitely right after the tendon rupture. And of course, I wouldn't use it for the tendon ruptures which are complete and after surgery. Is there any special recommendation for the use of focused shockwave and radial shockwave according to the ISMST? ISMST has the status of putting the radial shockwave therapy. They basically compare it more to, or they call it more like a pressure wave therapy. With the most members of ISMST that I spoke, they have good results with both. Although with the radial shockwave, It's more for the, let's say, muscle tendon areas, whereas with the focus and tendon bone junctions areas and calcifications. In general, you can use both for the therapies. It's very common, and I also recommend it, and I have a very good clinical results with this. It's to combine the therapies. To do the, for example, treatment of the insertion, let's put it into example, a tennis elbow. If I would have to use both, if I would have ability to use the both technologies for the tennis elbow, I would use the focus shockwave first, and I would treat the insertion of the tendon. Because what you want to do, if you want to like treat the tennis elbow, which has already some micro ruptures, it is much better and much pleasant also for the patient to treat it with the focus shockwave, because most likely you will be close to the humerus especially, and it will be painful with the radial. So you use focus shockwave for the small insertion, and then to treat the rest of the arm, if you want to, let's say, relax the muscles on the forearm, arm, and shoulders, I would use for the relaxation the radial shockwave therapy as a different approach. It doesn't make sense in this case to treat everything with the focus shockwave if you have ability to use both of them. Another question: what is the difference between this shockwave and that used for sexual weakness? I got this answer from a user, doctor. If I get the question correctly, you mean the erectile dysfunction. Basically, there is the difference in the parameters where you are using much lower intensities for the use of these shock waves. So the parameters are different, but the idea of how to produce these shocks, it can be the same. It's basically based on the technical parameters, but let's say the technical background can be the same. There are also different types of devices for the treatment of erectile dysfunction, like linear shock waves, but that's a little bit different technology. Can we see changes in X-ray after treating osteoarthritis knee with focus shockwave? Yes, definitely. That was osteoarthritis, not pseudoarthrosis. Sorry. In the osteoarthritis, unfortunately I don't have the experience from myself, and I know that it's used for the osteoarthritis for relieving the pain, to provide more blood supply. But I'm not sure if it's possible to, let's say, enhance the effect of the growth of the, the joint, basically the joint material. Who is eligible to use the focus shockwave and radial shockwave according to ISMST? I think this is not strictly based on the ISMST. This is more based on the regulation of each government. For example, most countries, Latin America, the physical therapists are not able to use focus shockwave on the doctors, whereas in other countries, it is possible to use both. In my opinion, I think if you are able to treat with the radial shockwave well enough, as a physical therapist, I didn't have any problem of treating with the focus shockwave as well. Of course, it will, for example, I will not treat the patients with, as a physical therapist, I will not treat the patients with the bone non-unions, simply because, for example, I do not have as a possibility of getting an X-ray always in the practice clinic. Okay, let's continue with we are almost closing to the end of the seminar, but I believe we will have to extend it if possible for a couple more minutes. Let's summarize the differences between focus shockwave and radial shockwave devices from different perspectives. So when it comes to the technical difference, as I mentioned in the beginning, our focus shockwave is based on electroacoustic principle, whereas the radial shockwave is based on the pneumatic principle driven by the compressed air. Another technical difference is that you are able to adjust the penetration depth due to these the coupling pads, and you are able to position the maximum area, the maximum intensity area, however deep you want. Whereas with the radial shockwave, you have these transmitters that are more like changing the shape of the wave, not the penetration depth. Another difference is the shockwave character. Basically, what is the difference in that wave that it's spreading out of these two respective devices? So in general, focused shockwave device has higher intensity. The maximum intensity is much higher than in comparison with the radial shockwave. The shape of the wave is different. The focused shockwave has this focal wave or convergent, which means that with the distance, it's getting smaller but stronger. With the radial shockwave is the opposite. It's divergent, which means that with the distance, it's getting wider and weaker. When it comes to the adjusting of the depth, I mentioned the coupling pads, but let's say the clinical difference or the clinical use for this is that with the focused shockwave, you can adjust the depth of the maximum intensity however you want. And at the same time, you can set how intense it will be. With the radial shockwave, you can only set how intense the shockwave will be, but not how deep it will get inside of the tissue. Question, you can start with the radial and finish with the focus. Absolutely, this is possible. I will not like to, I can share my experiences. I usually start with the focus shockwave, but in general, I could definitely encourage anybody to try whatever is best for them and whatever suits them the best in their practice. I think it doesn't, it's, for me, it would probably make very similar results. I can tell. I tried both. Of course, I tried like combining both, but in general, it's for the patients. I think it's better to try to start with the focus shockwave because it's not as strong. First, get familiar with this device, and then finish with the radial shockwave once they already know what's going to happen, how they will feel it. Some therapy recommendations. This is let's say very general, but in general we are using less shocks with the focus shockwave and also less therapies. Most of the time I'm not doing more than 4 therapies, whereas with the radial shockwave I'm doing 6 to 8 therapies very commonly, sometimes even more. And at the finishing of this webinar, I would like to share some studies that are very interesting for me. These are older studies also done with past devices, but they are very interesting on understanding on what shockwave can in general do. So I would like to share them with you anyway. So the first study that I have here is done with 126 patients, and it's concerning the bone non-unions. This one was done with the focus shockwave device, of course, and basically they were comparing the effect of the surgery and comparing it with the effect of the focus shockwave without performing of surgery of the non-unions. So they put two groups of patients, and one they treated with the surgery without shockwave, the other ones they treated with the shockwave without the surgery. And then they were looking on the results in the follow-up of 3 to 12 months. These are very interesting results if you look at the graphs in here. The dark blue color and the gray color are showing the results of how many patients grow, or they're on the X-ray, how many percentage of the patients were basically treated with the focus shockwave and they reformed the fractured bone. As you can see, compared to the blue, bright blue part, it's very similar to the effect of the surgeries, both in 3 months follow-up and in the 12 months follow-up. So in this study with 126 patients, they proved that it's comparable. The results are sometimes comparable with the long bone non-unions, both for the surgery and for the focus shockwave. This is interesting because, of course, focus shockwave, as we mentioned, do not have this possibility of the side effects of the risk of the surgery. So this is a nice insight of some possible alternative for the other treatments than only conservative or only the surgery. This is another nice study regarding the calcifications. Basically, you can see on these patients that they were treated both with the focused shockwave, and the pictures or the X-rays were taken before and after the performing the treatment. So the first one on the left is it's a female patient who was 42 years old, and both of these were calcification in the supraspinatus muscle. And the results in the second picture are done after only one session of the focused shockwave device, and the follow-up was done in 1 month. So you can see that only one treatment helped the patient to eliminate the calcifications in the supraspinatus, even in a short time period as 1 month. The second patient has the follow-up of 3 months and 3 sessions of the treatment of the focused shockwave. The third study, which was done in 45 patients, and it was done with it's a study done on plantar fasciitis and treatment of the focused shockwave compared to sham treatment, basically placebo. And we are comparing, in this study was compared on the visual analog scale, and they achieved a significant pain reduction. We can see it on this graph that in both cases, with the control treatment and the focused shockwave treatment, the patients get better. The difference is that with the patients that are treated with the focused shockwave, means with the dark blue part, were having the results much sooner, and also the results were much better. They were decreasing the visual analog scale by the higher amount. So this is how is it usually with the focused shockwave, that some treatments some indications they heal on their own, but what you can do, you can enhance the healing process and make it faster, especially with the high performance sportsman. This is important, and this can be a very useful tool. Another question: can it be used for the patients of all ages fracture healing? Yes. In the literature, what I actually noticed that it's used mostly in the older patients, because they are also more, let's say, more usually they have the risk of these fractures. The other thing is, if you talk about the children, of course you have to take in consideration the growth plates. So you have to avoid them, and this should be based on the X-ray evaluations. Another question: effects with fibrosis tissue, for example, adhesive capsulitis. Adhesive, in general, it's used for the fibrosis tissue, even such as scars. Me myself, personally, I don't have a experience with capsulitis, but for example, with the tissues such as scars that are painful scars, especially, and these like redness scars and swollen scars, it's possible to treat them. And usually what it does, it relieves the pain mostly for the patients. Another study, it's done on the tendon, and this is a very nice study comparing considering the collagen synthesis or increase of the collagen productions. This was done on the samples which were extracted from the human knee. It was the samples of the tendons, and these tendons then were affected by the focused shockwave and compared with the device, with the samples that have been not treated with the focused shockwave. And then it was counted how many or how much collagen was produced respectively for these two samples. So if we take a look at the graph, it's very well pictured that even after 1 day after application, the content of collagen per milliliter was actually increased even after 1 day of the focused shockwave therapy, and it was then increasing until the 12 days where the study then stopped the follow-up. But as you can see in these samples, the amount of collagen produced was immediately increased after focused shockwave when compared to the normally not treated tissue or tendon. This, of course, this study is done on the extracted samples, but at the same time, it's extracted samples from the human tissue. So I think it's a very nice study that can give us some information about what shockwave can do inside or outside the human body. Another study, it's for 144 patients with calcifying tendonitis of the shoulder. And in this study, they were comparing high energy shockwave and low energy shockwave, and also they have a control group. Basically, what was done in this shockwave, in this study, they were comparing the size of the deposit, the site of the calcifying compound or tissue, and also the reduction of the pain. Let's take a look at the graph, and you can see that dark blue one, focus shockwave with higher intensity, here it's 0.32 millijoules per millimeter square, have the best results and significantly better results when it comes to the size of the calcium deposit compared to both low intensity and a low intensity focus shockwave and also control treatment. So this is why it is important to have a device that has ability to set higher intensities as well as the lower intensities, because some injuries, some issues, they simply want to, or you simply want to treat them with higher intensities than others. So in this case, it proved that on relatively high amount of patients, that is better to use in this case the higher energy level. So this graph shows us how many millimeters square were, like the decrease in millimeters square on the X-ray of the calcifying tissue. With the same studies, they were also comparing the decrease in the pain with the visual analog scale, which is probably the most common scale that has been used for the pain evaluation. And you can see that again the results are corresponding with the previous ones. That with the higher intensities, the dark blue color, it is possible to achieve better results in the same time period. And I believe the last study that we have here was done simply on the tennis elbow with the 50 patients, and they were comparing radial shockwave and focus shockwave to each other. They were both treated with a radial and focus shock, respectively. They were treated with one group with radial shockwave, the other group of the focus shockwave. The important thing to mention here is that for the focus shockwave was used 3 sessions with 2,000 shocks, whereas for the radial shockwave, it was used also 3 sessions, but 4,000 shocks. So they were using double the amount of shocks of the radial shockwave therapy, as also it is recommended. So these are the results of the decreasing of the visual analog scale, of the decreasing of the numbers, of the values. And you can see that the focus shockwave therapy in this case was superior compared to radial shockwave. Whereas with the dark blue color, you can see that the decrease of the pain was, let's say, more significant when compared to the radial shockwave. On this one, it's pretty clear, and it also answers the question which device it's more sufficient for certain indications. I think it's safe to say that both of them are useful. If you are able to get your hands on each of them, you'll be able to provide the patients with a good results. Whereas in some cases, the focus shockwave, it's simply superior. It provides better results, let's say faster results, and sometimes even the results that are not only faster, but always more significant, like in this study, for example. How many days of break between the treatments of necessary and why? My focus is angiogenesis and blood vessel creation. Focus shockwave 1 or 2 weeks based on the condition treated. Radial shockwave therapy 48 hours. In general, for the angiogenesis, speaking from my experience, I am doing at least 1 week difference. If it can be break, if it's 6 days or if it's 8 days, it's doable. I think it's fine. With the radial shockwave, depends on what you are treating. If you are treating some patients it's after sport and you want to simply relax muscles, you can do it, as you mentioned, in 48 hours easily. It will not damage the patients. And if it's, especially in the sports medicine, it's very common that you want to treat the patients very often. very often, and you want to provide them with the fast results. For example, I would not treat the chronic tendinopathies sooner than with 1 week, just because you need the process of the healing. You need some time, and you don't want to constantly disturb this process. So that is probably based on my experience, also based on the experience of the members of the ISMS that I had a chance to speak with, and other users too. So I would like to thank you all for your attention and to taking time to participate in this webinar. I hope it was to some extent informative for you, that you learned something new.